So we'll go ahead. One of the feedback from the last session was that wanted to really work to make sure that we had these things started and over with in at least an hour. That way, those of you who are taking that break and have that allotted amount of time can get in and get out. So appreciate that feedback, and we'll work to do that. We're about 5 minutes late. The other was less me. So congratulations, you're going to get that. We've got a good presentation, I believe, that's highly informative and really is run a little bit more by these two ladies that are over here. I think we've got a good information, and we will sprinkle in a lot more fun. Apparently the trivia at the end of the last town hall was a big hit as well. So we will get through this so we can get to that. Just a couple announcements. One is that we talk a lot about how we are an independent 501c3, which means that you are the owners of this organization. So I'd like to announce that you are also the proud owners of the Willowbrook property, which is sitting right at the ambulance entrance, which if y'all have seen, it was a for sale sign that had a little pending sign on it as we were going through the process to get that done. So we now have that piece of property there, and and we'll, when we have it. So what I would like to do is see a sign on it that actually helps you find the ambulance entrance, because I don't know if it's y'all, but I like to pull into the education building and then turn around and go back around. Or I'm also very good at pulling into the Willowbrook property and then turning around and going back in. So I'm awesome at missing the ambulance entrance. Yes, with the crooked stop, it's that, or it's you're gauging it off the trash cans at the end of the street, right? So yeah, everybody knows that, right? Okay. So we have that, and we have some options that we can do. Also want to let you know that we have just added a new primary care physician. His name's Dr. Seeley. He comes out of the Madison area, and he will be coming up here, going into one of the offices in the 400 building. So we are excited to see him, and we will do the introductions with him at the new Doctor's Day, and then also going around with all the physician liaisons. But again, it is Dr. Seeley, and one of the interesting things when he came in here on just a Sunday, just walked around, loves the facility, and it's one of those times that usually when you're recruiting a physician, you really do roll out the red carpet, and he just came in on his own. And so there's a little bit of time that you go, okay, it's time to see if we practice what we preach, right? The one thing that he loves about the facility is he's actually looking for that feel of what the old Madison Hospital used to be. He likes the fact that he was greeted with a smile, that people are interested in you and about you. He likes the community, the feel of the community, and is just deeply excited to come up here. And is just looking for that high-touch medicine that he feels that they have moved away from in the area that he's in. So we're excited to have him, and excited to have someone that really does align with us from a culture and a philosophy standpoint. Other thing I just want to mention to you all is that we are kicking off a campaign, for lack of a better term, and that is to go down the path of becoming a deaf-friendly organization. It came to our attention actually through a lot of different ways, but that there's actually a high population of hearing impaired persons within Robertson County. Almost 3% of the population has a pretty significant hearing impairment. And on top of that, what we use is the phone, the little teletype phone. Well, the problem with that is that a large portion of the deaf population is also considered illiterate, especially from a medical terminology standpoint. And so asking them to read and type on a phone so they can communicate with the caregivers back and forth is not really providing the best care. So we have an effort that's being spearheaded by a couple of people within our organization, those that know Amy Link, and also we have Ms. Tina sitting over at the help desk, if y'all know her over at the IS department, have jumped in on that and are helping us. They're working with a group called the Sign Company out of Hendersonville, to really become a deaf-friendly organization. So you'll be hearing more and more about that as the days and time progress. I do think it's interesting the number of people that have raised their hands and said, hey, I took sign language in high school, or I did this, or I did that. It really is hitting a familiar chord with a lot of people, and I do think it's a huge need. So we'll be embracing that, and you'll just be hearing more about it. And finally, before I get off the stage and let the ladies talk here, I want to remind you that we are in our 20th anniversary year for Northcrest Medical Center. So in December of this year, we will be celebrating the big move from Jesse's house over to here. So we're putting that together. It's kind of funny. I was talking to Dr. Fosness the other day, and he said it's like an alumni club meeting. So a lot of people have expressed an interest of wanting to come back. We're working with Marilyn Warsham, and let's see who else is on that committee. We've got just Carol Cobb and just a couple of other folks that are very excited. I've been gathering a lot of information. So we're going to have our big 20th birthday party coming up in December. Just want to put that on your radar and let you know. So with that said, I'm going to turn it over to Miss Angie Beard and let y'all have fun for the rest of the time.
So I'm Angie Beard, and I'm the Chief Nursing Officer. And what I want to talk to you about, number one, this is hospital week, so we always kind of tell you what you do wrong. So I wanted to take an opportunity to tell you what you do right and give you a little bragging rights, first of all. Second of all, when you hear throughout the community, we always talk about how we're a high-quality organization. And then people ask you, well, what does that mean? I want to tell you what that means. The quality department put this together, and I just wanted to show it to you and go over it with you. Kind of look back at where we were and then where we're at now. So in 2011, our employee satisfaction score was 74.4. In 2014, our employee satisfaction score was 82.58. Then under our emergency department patient satisfaction, in 2012, the patient satisfaction was 25th percentile. In 2014, 68th percentile, and the current year to date is 77th percentile. Huge improvement. Outpatient satisfaction. We've gone from 51st percentile to 81st percentile. In ambulatory surgery, we've gone from 60th percentile to 64th percentile from 2012 to 2014. Then let's look at quality. Surgical site infections. These numbers are raw numbers. So these are actual patients. This is not a percentage. So each point that we decreased, that's a patient that we impacted their life. That's one less surgical site infection. Now what we do is we have these CUSP teams, and these CUSP teams are centered around improving patient care. And then we measure infections on surgical patients. One way that we improve that is we work with the physician's offices. We work with the lab to determine through lab work who has gotten a surgical site infection. So we try our best to find all of the surgical site infections that we can find. And then we develop teams called the SUSP team and the SIT team. And those are surgical site teams that go develop best practices based on like how to educate the patients and the families when they go home of how to take care of a surgical site and how to dress it, clean the wound, how we clean the area before surgery so that we can help prevent surgical site infections. And that's how we reduce that number. So every one of those points we've decreased, we've impacted a patient's life. Now, given our population of diabetics, smoking, obesity, that increases our risk of surgical site infections in this area. So we've really impacted a lot of patients' lives by decreasing those infections. Hospital-acquired VRE. Once again, each point is an actual patient. This is a vancomycin-resistant enterococcus. Anyone that has a history of this immediately goes on isolation when they're admitted to the hospital. We do this to keep the patients and our staff safe. Success with this is measured by our isolation practices and by our antibiotic stewardship. Now what this helps us also determine is how well we control our antibiotic usage throughout our community. Now people get really upset when they go to the doctor, they take their child to the doctor and they want an antibiotic prescribed for their child, but they can't get one. and then they call us and they're really mad because the doctor didn't give me an antibiotic in the emergency room? This is why. Because the more we use antibiotics, the more resistant all of these germs become to the antibiotics. So this tells us how well we're using antibiotics in our community and in our hospital. And this tells us we're doing a really good job with that. All of these, by the way, are called MDROs, multi-drug resistant organisms, okay? And this measures how well we're doing in our hospital controlling infections. Hospital-acquired ESBLs. Once again, we've been monitoring since 2011 to current. This is February, end of February current. This is extended spectrum beta lactamase. This is an enzyme that organisms develop that inactivate antibiotics. And you know, I'm going to call them bugs. These germs, these bugs, are very smart. And they develop an enzyme that inactivates antibiotics. We put these patients on isolation also. We're down to 0. We had a little uptick in 2013. We're back down to 0. This is 0 patients. Our next slide is hospital-acquired MRSA. This is methicillin-resistant Staph aureus. When you hear in the community that somebody got a staph infection, most of the time this is what they're talking about. They're talking about a staph infection. Some people think it's a staph, S-T-A-F-F, infection, but it's a S-T-A-P-H, staph infection. The difference on this is, on all of these MDROs, multi-drug resistant organisms, if we don't catch it in the first 3 days when a patient comes in, then we own it. So if you're a high-risk patient, we screen you for these organisms. We screen you for MRSA. And if you come back positive, then fine, it's not hospital acquired. If we don't catch it in the first 3 days and on day 4 this shows up, it's considered hospital acquired. So that's why we have all of these policies in place of how we catch this. If not, it's ours, we own it. It's considered we gave it to you. We've gone from 10 in 2012, current in February, 4. That's a huge difference. That's huge in this community. C. diff. Now this one is a little bit different. It is still, it's actually an anaerobic gram-positive rod, and it produces spores. And this one is not easy to kill. This is the organism that you must wash your hands. You can't use the foam. You have to wash your hands. The isolation on this one is different. We have a different signage on the doors. We educate the staff to treat this one differently because it's very easily transferred because of the spores. Look at this, 2. And the transmission is so easy, from 11 to 2. Core measures, in 2012 we were at 98.8%. In 2014 we were at 99.3% on core measures. That's how we compare against the nation. Core measures are evidence-based on outcomes of diseases and how well we adhere to these practices compared to the nation on heart attacks, pneumonia, congestive heart failure, stroke, decrease in blood clots, and surgical care. This is how well we do. Inpatient falls. This is how many patients, actual patients, we prevented falls on. We decreased the number of falls on. So we kept these patients safe through our implementation of best practices. And that's because a team of people sit around, a team of caregivers sit around and say, what can we do to keep our patients safe? And develop practices based on evidence-based research and on our practices here at Northcrest Medical Center. And this is really significant when we look at the next slide, which is restraint usage, and how well we have done in the decrease in the use of restraints. So the patients that are disoriented, we still manage to keep them from falling but yet we're not restraining them. That's incredible. Rapid responses and codes. Our goal is to have no codes outside of CCU. What that tells us is that the staff members and the families are utilizing our rapid response program. And they recognize when a patient's condition is deteriorating, and they call a rapid response, and they move that patient to a higher level of care. Central line days. We realize that devices are foreign bodies, and anytime you have a foreign body in a patient, you increase their likelihood of getting an infection from that foreign body. So we started in 2011 trying to get the foreign bodies out of the patients. There are times when foreign bodies, like central lines, and a central line is an IV that we put in a patient that goes to a large vessel in or near the heart that we can administer IV antibiotics or IV fluids through. And we try, there's some times that is necessary and that we have to have it, and we realize those times. But when it's not necessary, we get those lines out. On all of these devices, we talk about them every morning in the 9 o'clock bed meeting. And what is the criteria for use? Are they necessary? If they're not necessary, then the staff members go out and talk to the physicians and ask them, can we remove them? And this is how well we've done in the reduction of those device days. Because every time we get one of these out, we decrease the likelihood of getting an infection from one of these. The infection associated with this is called CLABSI, a central line associated bloodstream infection. It's been the Tennessee state initiative to decrease CLABSIs. We are one of the forerunners, at the top state level of reduction of CLABSI because of our efforts on this. Foley Catheter Days. Look at this. We've gone from 43, 58, all the way down to 16, 11. Of course, this year has not ended yet, I'll give you that. But still, from here to here, it's like a 40% reduction in Foley catheters. This is a tube that goes to the bladder to drain urine. We realized that most of these were staff convenience. Jenny Evangelist can remember when we first started this project. She and I sitting down and starting this project. This is so significant that people all over the state, hospitals all over the state, call and ask us all the time, how did you do this? Because they want to do what we did. They can't believe that we were so successful, and they want to know how we did it. The infection associated with this is called CAUTI, a catheter-associated urinary tract infection. Every time we take that catheter out, we decrease the likelihood of getting an infection related to that. Sepsis, or an infection from a catheter, carries a high mortality rate, by the way, especially in the elderly population. In the ER, we were having as high as 50 or plus insertions per month, and we've gone down to 5. Ventilator days. This is where we have the tube down the throat to help you breathe and put you on the ventilator. We've made huge, from like 800 here down to 600, and still trending downward on ventilator days. So we're getting them off the ventilator quicker and decreasing the risk of getting a pneumonia from being on the ventilator. Medication errors. Look at that. Once again, these are raw numbers, so these are actual medication errors. How many medication errors we've decreased. That slide just kind of speaks for itself, doesn't it? So what I'm trying to say is we're making a huge impact. We're making a huge impact on all of our patients' lives, but we're not done. We're still looking at ways to improve patient care, and our goal is still 0 patient harm. And that's still the goal that we're working toward. Do y'all have any questions about any of those slides or any of the information? Y'all look so solemn. That's some good information. That's good. We're doing good. Steve?
Has that affected our average length of stay any? Has it dropped with the reduction in all the, or we track that?
We do track length of stay. We have not correlated it with that.
Because that would be a huge money saver if it did reduce length of stay, wouldn't it?
It is estimated that one urinary tract infection cost a hospital around $70,000. So I know one hospital, the CNO carried around a Foley bag on her arm like it was a purse and said, "How do you like my $50,000 purse?" You know.
We even noticed carrying supplies. We said, "What's going on? They used to use these all the time," and all that increased. I mean, we noticed downstairs when changes is going on. You know, we always say, "What are they doing different up there?" It affects us even carrying supplies.
So most patients fall. If you think about how most patients fall getting up to go to the bathroom. So we took their Foleys out. We do not restrain them, and we reduce falls. Imagine how hard that is to do, and we did it. We accomplished all three. That's a wow factor.